Good evening, dear students. Welcome to you from Sri Rama Hospital, Jaggapet. Yesterday we discussed about the differentiated cancer of the thyroid. Today let us discuss about the other neoplasms of the thyroid gland. The ill-differentiated or less differentiated carcinoma of the thyroid, that is the anaplastic carcinoma of the thyroid. From the follicular cells, there are two types of malignant lesions. One is the differentiated carcinoma, the other is the undifferentiated carcinoma. Already we studied about the differentiated carcinoma, which is very common. Almost about 90% of the cases belong to differentiated carcinoma of the thyroid. Then anaplastic carcinoma of the thyroid. Clinical presentation, elderly females. Because it is anaplastic, there is rapid growth. There is diffuse irregular enlargement of the thyroid gland. Early infiltration to trachea and paravertebral muscles, carotid sheath, esophagus, and recurrent laryngeal nerve. So within months, you will find infiltration to these neighboring structures. Early spread to lymph nodes and distant organs by blood spread. You can see here swelling of 4 months duration with woody consistency, infiltration to sternomastoid and trachea. This is a case of anaplastic carcinoma of the thyroid. It has infiltrated the strap muscles, then it has infiltrated the platysma and the skin, and it has ulcerated, and it is profusely bleeding. All the history was only 3 months duration. The gland was infiltrating the trachea also. You can see here, this has infiltrated the trachea. Investigation, FNAC, isthmusectomy. Sometimes the anaplastic carcinoma is to be differentiated from the chronic thyroiditis, that is called the Riedl's thyroiditis, where there is diffuse infiltration of the thyroid gland with thick fibrous tissue. So because of this thick fibrous tissue, the gland enlarges and it feels very hard in consistency. So then there will be difficulty in differentiating from anaplastic carcinoma. So when you have doubt whether it's Riedl's or anaplastic carcinoma, then you can remove part of the isthmus. FNAC may be helpful. Sometimes FNAC may not be diagnostic. Then you go for isthmusectomy. So when you remove the isthmus, there are two benefits. Number one, you are getting a tissue for histological confirmation. Number two, you are removing a part of the ring of thyroid gland so that the tracheal compression can be minimized. Treatment of anaplastic carcinoma, palliative radiotherapy, chemotherapy with doxorubicin and other chemotherapeutic drugs. The treatment is difficult because very rapid course is there. So surgical treatment is, majority of the cases, it is not possible because the tumor has infiltrated many of the organs. Prognosis, usually death occurs within few months in most of the cases. Survival for more than 4 years is most uncommon. Next is the medullary carcinoma of the thyroid gland. It is a malignant neoplasm arising from the parafollicular or C cells which are derived from neural crest via ultimobronchial body. What is the function of C cells? What is the function of C cells of the thyroid gland? Yes, they secrete calcitonin. So that is why here also the cells produce calcitonin, 5-hydroxytryptamine, and also the prostaglandins. The tumors are not TSH dependent and do not take up radioiodine. The differentiated tumors, they are TSH dependent, but these are not TSH dependent. Types of medullary carcinoma. Familial medullary carcinoma associated with multiple endocrine neoplasia. So when I was talking to the anatomy of the thyroid gland, I told you that the parafollicular C cells are derived from neural crust. And the neural crust derived other organs. They may also participate in neoplasia combinedly. So then it is called the multiple endocrine neoplasia. Then second type is the familial without multiple endocrine neoplasia. Then non-familial cases. They constitute about 90% of the cases. So what is this MEN? Multiple endocrine neoplasia. There are two types. Type 1, it is chromophobe adenoma of the pituitary, hyperparathyroidism, pancreatic tumors like Zollinger-Ellison syndrome or insulinoma, and adrenal cortical tumors. MEN type 2A means pheochromocytoma, hyperparathyroidism, and medullary carcinoma of the thyroid. Type 2B means type 2A plus neurological lesions and mucosal neuromas of the lips and lids. Because the squamous cells also are derived from neural crest cells. So this is the types of medullary carcinoma. Clinical features. Familial cases occur in children and young adults. Sporadic cases occur at any age. Sex, there is no sexual preponderance. Clinical manifestations. There is a goiter with features of malignancy. That means induration, infiltration, and involvement of local lymph nodes as well as distant organs. Lymph nodes are involved in 50 to 60% of the cases. In familial cases, MEN may be associated. Diarrhea occurs in 30% of the cases because we have seen that the tumor secretes 5-hydroxytryptamine, so it can produce diarrhea. Investigation. Estimation of calcitonin. It is a tumor marker. It doesn't produce any lesions in the bone because it is not of such concentration. Only small quantities will be liberated. So that is why it is more helpful as a tumor marker. Estimation of urinary vanillyl mannalic acid is also known as VMA or catecholamines to screen the cases of pheochromocytoma because multiple endocrine neoplasia may be associated. If multiple endocrine neoplasia is associated, means this tumor may be associated with pheochromocytoma. The pheochromocytoma is there, then pheochromocytoma also has crisis. Just like thyroid crisis or thyroid storm, pheochromocytoma also can produce the adrenergic crisis. Whenever you operate upon a patient with pheochromocytoma, any operation, it can lead to the adrenergic crisis. Sometimes it causes atrial fibrillation and death of the patient and severe hypertension. That is why it may be a latent case. So that can be detected by doing only the urinary examination for vanillin mandelic acid or catechol-amine estimations. FNAC of the gland, I-131 scan, it shows only as a cold nodule because the tumor doesn't take up the radioactive iodine. Pheochromocytoma, if associated, should be managed before thyroidectomy is performed to avoid hypertensive crisis. Hence, estimation of VMA or urinary catechol-amine levels is essential in all cases of medullary carcinoma before undertaking for surgery. Not only that, all the relatives of the patient should be assayed for calcitonin levels to detect the neoplasm at an early stage. The relatives who are positive for elevated calcitonin levels need prophylactic thyroidectomy, though they do not have any lesion in their thyroid. Similarly, the same thing, relatives will be screened in some other familial disease, which we already studied, and we do surgery if they are positive. Can you tell me that? A familial condition where you screen the patients of the relatives of the patients, though they have no symptoms. The asymptomatic patients are also tested. Very good. Manogya, very good. It is familial polyposis, familial adenomatous polyposis. Now you can see here, prophylactic thyroidectomy specimen of a girl for positive genetic screening and calcitonin tests showing medullary carcinoma. Treatment of medullary carcinoma, total thyroidectomy with ipsilateral radical or modified radical neck dissection, because the tumor spreads to the lymph nodes in majority of the cases. So you have to do neck dissection also, either radical or modified radical neck dissection. Prognosis, this is an unpredictable tumor. If the disease is confined to the lymph nodes, prognosis is good. If blood spread is present, prognosis is bad. Next cancer of the thyroid is the lymphoma. Types primary, that means disease in the thyroid alone. Secondary, as a part of generalized lymphoma. That means lymphoma can arise in any place where there are lymphoid follicles. So not only from the lymph nodes, the lymphoma can arise from spleen. The lymphoma can arise from the intestines because there are lymphoid patches or Peyer's patches. So the lymphoma can arise from places where there are lymphoid follicles. So from the thyroid gland also the tumor can arise. But are there any lymphoid follicles in the thyroid gland? Just like Peyer's patches? There are only few lymphocytes, but there are no lymphoid patches or lymphoid follicles. Then where from this lymphoma can arise? This lymphoma arises from lymphoid aggregations in autoimmune thyroiditis. If the patient is having autoimmune thyroiditis, there will be lymphoid aggregations From these lymphoid aggregations, the lymphoma can arise. It may present like anaplastic carcinoma with rapid spread and rapid dissemination. It may arise from pre-existing Hashimoto's thyroiditis. Hashimoto's thyroiditis is the autoimmune thyroiditis. Investigation is FNAC. Treatment isthmusectomy to relieve the tracheal obstruction and for biopsy. Then radiation. Lymphomas are treated mainly by radiotherapy or by chemotherapy. If it is a localized lesion, we go for radiotherapy. If it is a generalized lymphomatous process, we go for the combination chemotherapy. Prognosis: primary, good prognosis; secondary, worse. So if it is a part of generalized lymphomatous process where thyroid also is involved, means it is a stage 4 disease. So the prognosis will be bad. So that is about the neoplasms of the thyroid gland. Any doubts in neoplasms? Okay, if you have no doubts, we'll proceed to the autoimmune thyroiditis. Pathology. It is autoimmune reaction to thyroid cytoplasm or for the thyroglobulin. That is the colloid. So whenever there is autoimmune reaction, first initially there will be inflammatory reaction. The inflammation may be subacute or chronic. Later, chronic inflammation will be associated with fibrosis. And when there is fibrosis or destruction of the gland, there will be hypothyroidism. Age and sex. Women around menopause are commonly affected. Presentation as a goiter, diffuse or solitary nodule goiter or atrophic thyroid. So when it gets fibrous completely, it contracts and you won't feel thyroid gland at all, but patient will be having hypothyroidism. This is called as the non-goitrous hypothyroidism. In early cases, there may be hyperthyroidism because when there is inflammatory reaction, there will be destruction of the globulin and release of the thyroxine hormones into the bloodstream. So there may be transient hyperthyroidism for just few days or few weeks. But hypothyroidism occurs in all cases eventually. The goiter is lobular with soft rubbery consistency. Differential diagnosis: multinodular goiter, carcinoma of the thyroid. Of course, in Hashimoto's disease, the surface is not nodular. It is not smooth. It is uneven. Because of the fibrosis, you have to differentiate it from the carcinoma of the thyroid gland. Complication is malignant lymphoma. Investigations: thyroid function tests. In the initial stages, they will be elevated, but in later stages, they will be decreased. Autoantibodies for thyroid gland. There are two types of antibodies. The antibody to the cytoplasm, that is the microsomal antibody, then antibody to the thyroglobulin, that is the thyroglobulin antibody. Both of them are elevated. FNAC, this is very useful investigation to differentiate it from simple goiter as well as from the carcinoma. Treatment: replacement therapy with thyroxine to treat hypothyroidism and to reduce the size of the goiter. So actually the size of the goiter is because of the inflammatory reaction as well as because of hypothyroidism. Whenever there is hypothyroidism, there will be reflex increased TSH levels. So these increased TSH levels will cause hypertrophy and hyperplasia of the thyroid gland, producing a goiter, enlarging the size of the thyroid swelling. If goiter doesn't reduce with thyroxine, steroids may be helpful. If goiter is large and causing discomfort, subtotal thyroidectomy is advised. If the goiter increases suddenly and does not respond to thyroxine, lymphoma should be suspected. Because lymphoma is a complication of this Hashimoto's thyroiditis. So this is about the autoimmune or Hashimoto's thyroiditis. The next is the Dickwer-Weins thyroiditis. It is subacute inflammation of thyroid and it follows a viral infection. Now in this present corona pandemic, you can see some of the cases of this Dickwer-Weins thyroiditis also. Clinical features: fever, pain in the neck, form irregular enlargement of both lobes of thyroid gland. Investigations: serum thyroxine may be high because of the inflammatory reaction. Autoantibodies are absent. FNAC helps. Treatment: it is a self-limiting disease because it is a viral disease. If there is a lot of pain, prednisolone 10 to 20 milligrams per day can be given for 7 days. Then the next condition is called the Riedel's thyroiditis. It is very rare. Here thyroid is replaced by fibrous tissue which spreads into surrounding tissues, making the gland hard and fixed. What do you call such type of lesions? Where the normal tissue is completely replaced by fibrous tissue and this fibrous tissue spreads into the surrounding tissues. What do you call these conditions? It's very good. It's called fibromatosis. Okay, there is a doubt from Manognya, that is, if by chance, if you can identify anaplastic carcinoma before it spreads to the local tissues, can we operate? Yes, definitely we can operate if it is localized to the thyroid gland. Then prognosis will be better than the infiltrated variety, but by and large, even though you operate upon the thyroid gland, there will be distant metastases and local recurrences. This is a very ill-differentiated tumor. So ill-differentiated tumors, though after removal, you cannot remove complete microscopic clearance. There will be still some microscopic foci of thyroid gland remnants. So those things, because it is not taken up by radioactive iodine, so you cannot irradiate them by even I-131 scanning or I-131 medication. So those microscopic foci, they will again cause the recurrent thyroid nodules as well as the lymph nodal as well as visceral metastasis. So by and large, whatever you do, these cases, they will have a worse prognosis. But by intervening at the earliest, when the thyroid gland only is enlarged, then there will be better chances. Okay? Okay, if thyroid gland is completely replaced by fibrosis, that means it belongs to a condition called the fibromatosis. So already we discussed about fibromatosis due to no cause. That means normally the fibrosis develops because of chronic inflammation or because of trauma. So without these two, there will be fibrosis of the whole gland. Clinical features: there is presence of goiter, which is hard and fixed to the surrounding tissues. It pursues a very slow and chronic course. So by that we can differentiate from anaplastic cancer. Differential diagnosis from anaplastic cancer. Investigation and treatment: histoplasmectomy to relieve respiratory obstruction and for histopathological confirmation of the disease. Treatment: high dose steroids, tamoxifen, and thyroxine supplementation. Because as the gland is replaced by fibrous tissue, there will be hypothyroidism. So you have to replace thyroxine. So this is about the inflammatory disorders of the thyroid gland. Okay, Santi has asked about a brief description of a brief review of medullary carcinoma. Medullary carcinoma arises from the parafollicular C cells, which are derived from ultimobronchial body, but the main parent cell is the neural crest cell. That is why this tumor may be associated with multiple endocrine neoplasia. And this tumor secretes calcitonin, 5-hydroxytryptamine, and kinins. So there will be thyroid swelling, there may be history of familial history. The important points to remember in medullary carcinoma are: number one, it produces calcitonin, 5-hydroxytryptamine, and bradykinin, which are responsible for diarrhea. It may be associated with pheochromocytoma and other multiple endocrine neoplasias. So in every case of medullary carcinoma proven, which is proven by FNAC, then you must study the calcitonin levels, which is a tumor marker. Along with calcitonin, you must also evaluate VMA levels or catecholamine levels in the urine. That will tell you whether the patient is having associated pheochromocytoma. If such is present, that should be treated first and later the medullary carcinoma. Medullary carcinoma spreads fast. In majority of the patients, there will be associated lymph nodal metastasis. So the treatment here is total thyroidectomy, because there will be usually microscopic foci of lymph nodal metastasis which will grow later. You must do block dissection of the neck, either bilateral or ipsilateral. So block dissection, if it is done on both sides, you can go for modified block dissection on one side and block dissection on the other side. Prognosis is of course not good, because these are all, except the differentiated cancers of the thyroid, all the remaining cancers, they have a bad prognosis. Okay, any more doubts? If you have no more doubts, we will close this topic on the tumors and inflammations. So we have studied about the simple goiter, toxic goiter, neoplastic goiter, inflammatory goiter. So these are the main four types of goiter we encounter. It is not neck exploration, it is called as neck dissection. Neck dissection is equivalent to block dissection of the neck. Block dissection of the neck means you remove all the lymph nodes in the neck on one side along with their lymphatics. So where are these lymphatics present? Mostly they are present in the fascia and in the sheaths. So fascia is mainly general listing layer, prevertebral layer, pretracheal layer, and the carotid sheath. So these fascia and the lymph nodes. So your aim of doing a block dissection is to completely eradicate the lymphatic zone from the neck. So when I said deep fascia of the neck means the deep fascia of the neck includes the sternomastoid muscle also. It includes the trapezius muscle also. So in block dissection, what you do is you remove the general listing layer of deep fascia of the neck on one side along with sternomastoid. You remove the carotid sheath, and carotid sheath is intimately adherent to the jugular vein. So you remove the jugular vein and all the lymph nodes from the submental group to the clavicle and mandibular sterni. Both central group, I listed all the groups, you see, level 1, level 2, level 3, level 4, level 5, level 6. So all these 6 groups of lymph nodes along with their lymphatics are removed as one block. This is called the radical neck dissection, also called as block dissection of the neck, or simply called as neck dissection. In many of the lymph nodal metastases into the neck, this operation is performed. There is a modified procedure. In the modified procedure, what you do is you spare the sternomastoid muscle or you spare the internal jugular vein. Then it is called the modified neck dissection. So when you are doing bilateral neck dissection means you have to do surgery on both sides. So remove both the sternomastoids, both the internal jugular veins, and all the lymph nodes on both sides. So that will produce a lot of morbidity. And when you ligate internal jugular vein on both sides, there is no drainage, venous drainage from the skull and brain. That is why on one side you go for modified neck dissection, wherein you preserve jugular vein on one side but remove jugular vein on other side. So bilateral lymph nodal metastasis you do because medullary carcinoma is a diffuse lesion, not confined to one lobe. So it produces metastasis on both sides. So if metastasis is there on both sides means you must remove both sides lymph nodes. So when you are going to remove both side radical neck dissection means it becomes a lot of complications. That is why you preserve sternomastoid and the internal jugular vein on one side, remove it on the other side. So that is called modified neck dissection. Parathyroids means block dissection is radical. Radical or block both are same. Block means if you remove the lymphatic and lymph nodes and the primary tumor as one piece, then it's called block dissection. Radical also the same thing. To check parathyroids, what do you want? I can't get your question, Santi. Okay, during surgery, how to identify parathyroids? Is this your doubt? Okay. Anyway, I will tell it tomorrow because I am going to tell you something about operative procedures tomorrow. So when I tell you about the operative procedures, then I will explain to you how the parathyroids are safeguarded. Okay, Manogya has a doubt. She didn't follow the neck dissection, so I will repeat again. Neck dissection means it is neck dissection, also called as the radical neck dissection, also called as the block dissection of the neck. So this is done whenever there is lymph nodal metastasis, either from thyroid disease or from oral cancer or from pharyngeal cancer. So whenever there is lymph nodal metastasis into the neck, you do this procedure. The aim of the procedure is removal of all the lymph nodes on one side of the neck along with their lymphatics. The lymphatics are there in all the fascia of the neck. The fascia of the neck being general twisting layer, prevertebral fascia, pretracheal fascia, and the carotid sheath. So you have to remove all these fascia. So if you remove the general twisting layer means you must remove the sternomastoid muscle also. If you want to remove the carotid sheath means you must remove the internal jugular vein also. So radical neck dissection means it is removal of all the groups of lymph nodes from the lower border of the mandible to the upper border of the clavicle and manubrium sterni, along with general twisting deep fascia, sternomastoid muscle, fascia covering the trapezius, omohyoid muscle, internal jugular vein, and the lymph nodes. So this is called the radical neck dissection. If you preserve sternomastoid or internal jugular vein, we call this as modified neck dissection. Okay? Any more doubts? If you have no more doubts, we will go to the next topic, that is the solitary thyroid nodule. So these are all the solitary nodules. Here, this is a solitary nodule. This is a solitary nodule. This is the thyroid gland. Here you can see the solitary nodule. This is a large solitary nodule. The isolated enlargement of one lobe of thyroid gland or presence of a single nodule in any lobe or the isthmus of thyroid is considered as solitary nodule goiter or discrete nodule goiter, also called as solitary thyroid nodule. The recent nomenclature is the solitary thyroid nodule. It is abbreviated as STN. Importance of solitary nodule. Many diseases of thyroid gland present as solitary nodules, clinically indistinguishable from malignant lesions. Some of them may be malignant, though appear benign. Incidence of malignancy in a solitary nodule. That means various types of diseases. Yesterday also you told me various types of diseases manifest like solitary thyroid nodule. So now, if a patient comes to you with a nodule in the thyroid gland, what are the chances of it being malignant? So that is the incidence. If it is a solid lesion, the chance of malignancy being 24%. If it happens to be a male patient, solid lesion, the chance of malignancy is 48%. That means almost 50% of the cases are malignant. So that means in males, if there is a solitary nodule in the thyroid gland, means it is malignancy with a chance of 50%. Females 12%. Then if a cystic lesion, it is 12%. Males 24%, females 6%. The risk is more in males than females and solid than cystic. The risk of malignancy in a diffuse goiter is around 3%. Diseases presenting as a solitary nodule. Simple goiter, adenoma of the thyroid, carcinoma thyroid, that is early differentiated cancer, cyst of the thyroid, toxic nodule, rarely Hashimoto's thyroiditis. Except toxic nodule, all other diseases present clinically alike. So simple nodule, adenoma thyroid, differentiated carcinoma thyroid, cysts of thyroid, so they all have similar clinical manifestations. What is clinical manifestation? Single lobe enlargement, or you find a spherical nodule in the thyroid gland. It moves on swallowing, it doesn't move on protrusion tongue. It is mobile, lymph nodes are not involved, berries are not present. There are no visceral metastasis. There is no toxicosis. So clinical presentation, incidence 3 to 4% of adult population in UK and USA suffer from these solitary nodule goiters. Sex incidence, females predominant. Why females thyroid disease is more common? Why thyroid disease is more common in female population? Very good. The presence of estrogen receptors on the thyroid gland. Age of occurrence is between 20 to 40 years. Unilateral enlargement of thyroid gland or swelling from the isthmus. Swelling is smooth, mobile, and firm. The size is variable. There may be sudden increase in size of the swelling or pain in the swelling due to hemorrhage into the swelling. So whenever the cyst is there may be bleeding into the cyst. Then that produces severe sudden pain as well as sudden increase in size of the swelling. Sometimes this sudden increase in size of the swelling may cause tracheal pressure and may cause dyspnea also. Just I will ask one question here, just to check how you respond if a patient comes to you with sudden increase in size of a solitary nodule with dyspnea. So immediately what do you do? You are in the OP, outpatient. So a patient comes running to your OP, telling that just then she developed a large size of the goiter and there is severe pain and there is dyspnea. What do you do? Of course, I have not told you this point, but you just imagine and tell me. If there is a previous history of nodule is there, the nodule was there for the past 10 years. Suddenly she developed an increase in the size with severe pain associated with dyspnea or stridor. What do you do now? What do you do? You are in the OP, outpatient. Other students, please respond. No history of trauma. Other students also, please respond. So far, no one has given a correct answer. Yes, you do confirm by ultrasound scanning. Then what do you do? The patient is dyspneic. Her oxygen saturation is falling. There is a lot of stridor. She is becoming cyanotic. What do you do? Okay. All of you have not mentioned the answer required. Anyway, so these things you will get the idea if you are routinely attending the operation theaters and following the patients. Now the patient condition is, patient main problem is not thyroid problem. The patient problem is life and death problem. Why life and death problem? Because patient is having stridor and the stridor is going on increasing. Why? Because there is a swelling. There is swelling over the neck which is causing the compression. What is the history? Patient says that she was having a swelling in the neck for the past 10 years and in the past 10 minutes she developed this large swelling with severe pain and dyspnea. So what does it mean? Whenever there is sudden increase in size of the swelling of thyroid gland associated with pain, it is due to hemorrhage into the swelling. So there is hemorrhage means it will continue. That is causing pressure. So the best thing you can do is to restore the airway passage. So how to restore the airway passage? Yes, very good. Not incision. Incision is not required. Put a needle. Put a needle and aspirate. So all the blood will come out. So if you do aspiration, the blood will be drained. Then you can plan for surgical management or ultrasound scanning or whatever you want. You can do it later. So the immediate first aid measure to save the life of the patient from tracheal obstruction is wide bore needle aspiration. For example, it is not hemorrhage, it is something else. What do you lose by putting a needle into the thyroid gland? Nothing will happen. So you aspirate whole blood, apply some pressure over the swelling, then you do ultrasound scanning, then if necessary, you can go for surgical management. So this is what you must do. Okay, aspiration, very good. So a midline swelling like this. So you see here a midline swelling. So whenever you see such midline swellings, you have to know whether it is a solitary nodule or a diffuse goiter. Solitary nodule or a diffuse goiter. Clinically. For that, what you do, you have to palpate the trachea on either side of the swelling. If you can palpate the tracheal rings clearly, that means that this side lobe is not enlarged. So a midline swelling sometimes gives you a confusion. Is it a solitary swelling or a diffuse swelling? Suspicion of malignancy, solitary nodules in males, solitary nodules in persons with extremes of age, nodules more than 5 centimeters in diameter, and area of induration or irregularity of the nodule, presence of associated features like hoarseness of voice, restricted mobility of the swelling, presence of palpable cervical nodes or bony swellings. History of radiation during childhood. Sorry. So these are the 5 conditions where you suspect malignancy. Of course, there is a doubt from Santi that what should we do if the case is an anaplastic carcinoma with dyspnea? Anaplastic carcinoma with dyspnea will not be produced within minutes. It will be over a period of days. So if it is an anaplastic carcinoma, then the patient is having stridor, then the best thing you do is the isthmusectomy. You remove the isthmus of the gland. That will make the patient free from the tracheal obstruction. Investigations for a solitary nodule goiter. Thyroid function test to exclude toxic goiter. Estimation of autoantibodies of thyroid to exclude Hashimoto's thyroiditis. Fine needle aspiration cytology, RFNAC. Ultrasound scan to identify cystic lesions and to identify lesions in the other lobe. Though clinically it may manifest as a solitary nodule, but the other lobe also may have the nodules, which are occult. I-131 scanning only in selected cases of solitary nodules. That means solitary nodules associated with elevated thyroid function tests. FNSA. It is the investigation of choice in planning the treatment of thyroid nodules. The accuracy is dependent mostly upon the efficiency of the cytologist. So the pathologist who looks at the slides and gives the report, so on him the accuracy depends. So what you do is, you take a 20 ml syringe and you study the nodule between your two fingers, pass the needle into the thyroid gland, and you aspirate. While you are aspirating, you just move the needle in 3 or 4 directions. That means you want to sample the whole thyroid nodule, not at one place. So while you are advancing, you aspirate. Then you withdraw it while you aspirate. Then you change the angulation and again advance and then aspirate. Like that, you pass the needle in 2 or 3 or 4 directions and aspirate. Of course, I am showing here the example of a lump in the breast. After aspiration, you won't get much of fluid. If it is cyst only, you will get a lot of fluid. If it is solid lesion, you just get 3 or 4 or 5 drops of fluid. So these 5 drops of fluid, you must squirt it onto a glass slide like this. So you push them onto the glass slide. Then you take another glass slide. With that, you make a smear. So after it is smeared on the slide, you place this slide in a container containing absolute alcohol, absolute propyl alcohol. So what will happen? The alcohol will cause dehydration. It draws water. So with this, the film gets dehydrated. The film means what you have smeared there, that gets dehydrated. So only cells will be there that get stuck to the slide. So this is called fixation. So you fix the specimen to the glass slide by putting it in isopropyl alcohol 50%. That is, you keep it there for 20 minutes in this chamber. After 20 minutes, you take it out, dry the specimen, and send it to the cytologist. The cytologist will now stain the slide with the help of eosine and hematoxylin stains. Simple stains. They won't use complex stains to study the cells. So just they want to see the cellular shape, the architecture, the cytoplasm, the nucleus. So especially for the malignancy features, they study the cells. So basing on this classification of the FNS reports, already I told you, TH1 means non-diagnostic, 2 means non-neoplastic, 3 means follicular neoplasm, 4 means suspicion of malignancy, 5 means malignant, frankly malignant. So this is a case of simple goiter where you see hematoxylin stained colloid with normal follicular cells. So this is a nodule is because of the simple goiter. Now you can see the follicles, so the cells are arranged in follicles as groups. So whenever you see such arrangement, you call this as the follicular neoplasm. By looking at these cells, can you say whether it is follicular malignancy or follicular adenoma? So by looking at this FNSC slide, can you say whether it is follicular carcinoma or follicular adenoma? Okay, then tell me, by histopathological examination means what factors will differentiate benign tumor from malignant tumor in follicular neoplasm? Very good. By capsular invasion and vascular invasion. Very good. Wonderful. So here you can say only it is a follicular neoplasm. You can't specify whether it is a follicular carcinoma or follicular adenoma. Again, you can see a large follicle here. You can see large cells which are not uniform in shape and size, and they have, some of them has the hyperchromatic nuclei. So these are all the pleomorphic cells, that means malignant cells. This is a case of anaplastic carcinoma. Now you can see papillary projections like this. So cells arranged in papillary projections, they indicate papillary carcinoma. So anaplastic carcinoma, you find multiple hyperchromatic nuclei. So cytoplasm almost is insignificant here. Sheets of hyperchromatic nuclei containing cells. FNAC helps to make diagnosis of three types of cases. Benign lesions, that is simple goiter, where you find a colloid nodule, Hashimoto's thyroiditis, then malignant lesions like papillary carcinoma, medullary carcinoma, anaplastic carcinoma, lymphoma. So they can be diagnosed on FNAC. Of course, second is suspicious or ambiguous in case of follicular neoplasm. So that is about the fine needle aspiration cytology. Then ultrasound scan. It is mainly to identify cystic lesions and solid lesions. In Hashimoto's thyroiditis, you will find a lot of lymphocyte aggregations with normal follicle cells or cells which were undergoing necrosis with fibrosis. So you will find fibrotic bands, necrotic cells, lymphoid follicles. And ultrasound scan also helps to identify malignancy in a solid nodule. The features suggesting malignancy are irregular halo, punctate calcification, hypervascularity demonstrated by Doppler scan, and solid lesions. Isotope scan. Isotopes used are I-131 with a half-life of 8.1 days, I-132 of 2.3 hours, I-125 of 60 days, I-123 of 13 hours. Actually, I told you in one of the previous classes that the superscript denotes atomic number. No, it is incorrect. It denotes atomic mass number, not atomic number. It denotes the atomic mass number. Did you verify the right in atomic mass number? It is not 126, it is 127. 127 is the atomic mass number. Yes, that's right. So these are all the isotopes, 123, 125, 132, 131. The commonly used one is the I-131. I-132 is having only 2.3 hours. Then the other isotope used is the technetium 99M. Types of nodules: hot nodule or hyperactive nodules where radioactive iodine is more concentrated, warm nodules and cold nodules. So this is a cold nodule. So you can see here this is a normal thyroid lobe which took the iodine 131, and this is the thyroid lobe, but this part is also part of the thyroid lobe, but this particular area didn't take up radioactive iodine. So that is why it's called as the cold nodule. What does a cold nodule signifies? What does a cold nodule signifies? That means it is hypoactive or non-functional nodule. Non-functional means it is living, but it is not taking up radioactive iodine, it is not secreting thyroxine hormones. That is non-functional. Functional means it is taking up radioactive iodine or iodine and synthesizing thyroxine and triiodothyronine. So this particular nodule is a cold nodule. So whenever you find non-functional nodule, you have to think of number 1, malignancy. Most of the malignant tumors of the thyroid gland, they are non-functional. Number 2, a degenerated nodule. Number 3, a cyst. This is an example of hot nodule. %80 of cold nodules are secondary to colloid cysts or adenomas. Isotope scan is performed mainly in multinodular goiter to identify the areas of hyperactivity. Treatment of solitary thyroid nodule. Cold nodule means it is a non-functional nodule. It is not able to take up iodine. So when it is not taking up iodine means it is not synthesizing thyroxine hormones, thyroid hormones. The causes for cold nodule being, most of them are cystic masses or degenerated masses or the neoplastic masses. So cold nodule means earlier days it was considered to be a malignant nodule. But later it was found that majority of the cases are because of cystic lesions or degenerations, and only few of them are because of neoplasms. The neoplasms can be due to a follicular adenoma or due to carcinomas. No, malignant lesions don't produce T3. They don't produce T3 nor T4. If they produce more of T3 and T4, then malignancy should be associated with thyrotoxicosis. So we have not seen thyrotoxicosis in any of the malignant lesions. So malignancy is not associated with increased functionality of the nodules. Treatment: if a person comes to you with a solitary thyroid nodule, what are the indications for surgery? Suspicion of malignancy. Just now I told you about suspicion of malignancy. Please tell me, what are the points for suspicion of malignancy in a solitary thyroid nodule? When do you suspect malignancy? If there are 3 eyes, you don't suspect, you confirm the diagnosis. If the patient is having solitary nodule means a mobile, freely mobile, firm, spherical nodule in one lobe without any lymph nodes, without any metastasis. So that is called solitary thyroid nodule. If the thyroid nodule is associated with fixed to the trachea or lymph nodal metastasis or bone metastasis, then you don't call it a suspicion, you call it as only malignant lesion. Very good. Manogya told me the correct answer. Any nodule occurring in the males, extremes of age below 20 years, more than 50 years, size more than 5 centimeters, history of radiation during childhood. So these are the things where you should suspect malignancy. And also in recurrent cysts, FNAC shows malignant cells or follicular neoplasm. Toxicosis, indications for surgery of solitary nodule. One is suspicion of malignancy, second is toxicosis, third is cosmetic, fourth is pressure symptoms on trachea. Next is the large size. Management plan. First do clinical examination to confirm that it is a solitary thyroid nodule. Then you do thyroid function tests. Thyroid function test may be hyperthyroid, that T4, T3 elevated. Then you do either surgery, that is lobectomy, or give radioactive iodine to ablate the gland. The report may be euthyroid. Then you go for FNAC. On FNAC, when you aspirate, you will get complete cystic swelling. That means you get about 10 ml of fluid. The swelling has completely disappeared. That means it is a cystic swelling. So it may be subject that for cytology. If the cytology report comes as a benign, then you just completely aspirate and then watch the swelling, whether the swelling again recurs or not. If FNAC gives the report as malignancy, the treatment is surgical management, depending upon the type of the lesion. Partly cystic and solid. That means you aspirate, you get about 5 ml of fluid. Then when you examine the swelling, still a mass is felt. That means there is cystic and solid components. So the report may be colloid nodule, Hashimoto's thyroiditis, malignant, follicular cells present. So any of these 4 reports can be there. So if it is a partly cystic or completely solid, so when you have the report like this, what do you do? Colloid nodule. If the patient is having cosmetic problem, pressure symptom, large size, suspicion of malignancy, do lobectomy plus biopsy. Other cases, if the symptoms are not there, then you go for wait and watch policy. If the report is Hashimoto's, then go for medical treatment. If it is a follicular neoplasm or malignancy, you do surgery. Surgery means lobectomy. So here, if the biopsy comes as malignancy, you go for again reoperation to do total thyroidectomy. So this is what you do in case of solitary thyroid nodule. Post-surgical management, The lobotomy specimen is sent for histopathological confirmation. If it is benign, go for T4 supplementation. If it is malignant, planned according to the type of malignancy. Cyst of thyroid. We have not discussed separately about cyst of thyroid. So, what is cyst of thyroid? It is degeneration of a colloid nodule, or can be due to papillary carcinoma, cystic involution of follicular adenomas, hemorrhage and organization of clot into a nodule of thyroid. So if a nodule has a hemorrhage, then it gets organized. The clot gets organized, and later there will be fluid formation. This is a case of papillary carcinoma thyroid, where you see a nodule, but in the center of the nodule you find cystic lesion. Treatment of cysts. Indications for surgery. Blood-stained fluid aspirate on FNAC. So every cyst you have to do FNAC. If on FNAC you find blood, you have to do for surgery. Or there is residual solid mass after complete aspiration of the cyst. Rapid recurrence of the cyst after complete aspiration. The presence of malignant cells on FNAC study. So in these conditions, you have to go for surgery. So please by heart these indications. The same indications hold good even for breast cyst in the breast also. So procedure is lobectomy operation. If these are not there, you call them as simple cyst. You can aspirate for 3 to 4 times. If refills even after 4 times, surgery is indicated. Isolated nodule versus dominant nodule. So there are two conditions which are almost similar. Isolated nodule or solitary nodule, and a dominant nodule. What is dominant nodule? Discrete nodule, that means solitary nodule, with palpable contralateral lobe of thyroid gland is called dominant nodule. That means this is the normal thyroid gland. Now, for example, if the patient develops a solitary nodule in one lobe, so this right side is having solitary thyroid nodule. On clinical examination, you notice there is mild enlargement of the left lobe. Left lobe also is clinically palpable. Then you call it as dominant nodule. What is the significance of this dominant nodule? The incidence of malignancy in these nodules is of that of isolated nodule. We have seen the statistics of the isolated nodules, malignant. Males 48%, females 24%, if it is solid lesion. Cystic means males 24%, females 6%. So, but if this is a dominant nodule, that becomes off. So this is about solitary thyroid nodules and cysts in the thyroid gland. So with this, we are completing the topic on thyroid gland. Any doubts? If you have no doubts, I will go to the topic of clinical examination of a thyroid gland and operations for thyroid gland. Just now I said dominant nodule means it is solitary thyroid nodule with palpable other lobe. This is normal thyroid. If you find a mass in the one lobe, the other lobe is not clinically palpable. Normal thyroid is not palpable. When you palpate over the neck, you cannot feel a normal thyroid. Only when thyroid becomes form in consistency or increased in size, then only you will be able to feel the thyroid lobe. So solitary thyroid nodule means there is only a nodular or single nodule in one lobe. The other lobe is not palpable. That is solitary thyroid nodule. Then what is dominant nodule? A nodule is felt in one lobe. The other lobe is mildly enlarged. You can feel the other lobe is also mildly enlarged. So that is called a dominant nodule. So wherever you find a solitary thyroid nodule with associated enlargement of the other lobe enlargement is only mild. The other lobe is also enlarged to a large size. Then it becomes a colloid goiter or multinodular goiter or other diffuse goiters. Okay, if you have no more doubts, I will go to the topic of examination of thyroid gland and operations on thyroid gland. Just I will give you small case report and then I will go to the examination. A female patient aged about 40 years complained of swelling in front of the neck since 5 years. It is slowly growing in size and painless. How do you arrive at the diagnosis? So suppose this patient was given to you. So the patient was having a swelling in front of the neck for the past 5 years. So how do you examine and how do you come to a diagnosis? The stepwise method. First, test for the plane of the swelling, whether it is skin, subcutaneous tissues, or deep to the deep fascia. How do you test? Tell me. For example, this swelling is there. You can make out this swelling here, isn't it? This vowel swelling. So is it a skin swelling, subcutaneous swelling, or swelling deep to the deep fascia? And of course, deep to deep fascia means it can be from thyroid swelling. So what tests you do? From skin swelling. When do you say a swelling is from skin? Skin pinch test, very good. Skin pinchability. Number 2, second point also is there. Sternocleidomastoid contraction is for relation to the muscle. I am asking only one question, that is simple question. How do you say that it is a skin swelling or not? If it is a skin swelling, there will not be any pinchability of skin over the swelling. That means skin pinchability. So this is the swelling here. So with your fingers, you try to pinch. If you can pinch the skin, that means pinch the skin all over the swelling. That means it is not from the skin. Second point to see is movement of the swelling with the skin. That means you slide the skin, you move the skin, then the swelling moves if it is from skin. If it is not from skin, if you slide the skin only will move. The swelling won't move. So these are the 2 points. Swelling moves with the skin as both vertical and horizontal. Number 2, skin is not pinchable. So that will tell you the skin swelling. Tell me one example of skin swelling in the neck, in the front of the neck. Dermoid cyst is a subcutaneous swelling, as it is sebaceous cyst. Lipoma is a subcutaneous swelling, it is not a skin swelling. Lipoma is a subcutaneous swelling. So skin swelling means 90% of the cases are due to sebaceous cyst. Do you continue to have the discussion by chatting or through mic? Do you want to continue with chatting like this or with mic? Okay, that's fine. If it's comfortable for you, please go ahead, no problem. Okay, then swelling arising from subcutaneous tissues. How do you say? When do you say a swelling is subcutaneous? Skin is pinchable all over the swelling. Number 2, it is superficial to the deep fascia. So next question is, how do you say whether swelling is superficial or deep to the deep fascia? What test you do? How do you say a swelling is superficial to the deep fascia? No, not like that. So whenever you want to see the relationship of a swelling to a structure, that means it is a fascia or a muscle. What you must do, you must make the fascia or the muscle to contract or to become stiff. Once they become stiff, for example, this is fascia. It is lax. There is swelling here. Okay? What you should do is you stretch the fascia, you make the fascia taut, then the swelling may become prominent. If it is underneath, you are able to see the swelling when it is lax, but when the fascia becomes taut, you can't see the swelling. So when the fascia is lax, you can see the swelling like this. Swelling like this, projecting under the skin. But when you make the fascia taut, then you will not be able to see the swelling. So what is happening? When the fascia is made taut, a swelling which is situated superficial to the fascia becomes more prominent. A swelling which is situated deep to the deep fascia becomes less prominent. Same thing with the muscle also. The swelling is situated superficial to the muscle. By contraction of the muscle, the swelling becomes more prominent. If the swelling is situated deep to the muscle, by contraction of the muscle, the swelling becomes less prominent. The simple laws of physics, that's all. Did you understand this point? Then, how do you make the fascia contracted? Or how do you make the fascia taut? How do you make the fascia taut or stiff? You know how to make the muscle contracted, but how do you make the fascia taut or stiff? Very good. So wherever the fascia is there, that part of the fascia has to be stretched. Front of the neck. Front of the neck fascia can be stretched by extension. Front of the neck fascia can be relaxed by flexing. That is why whenever you examine thyroid gland, you must make the patient flex his neck so that the fascia gets relaxed. When the fascia gets relaxed, you will be able to feel the thyroid gland clearly. So test for the plane of the swelling, that is whether it's skin or subcutaneous tissues or deep to the deep fascia. If it is subcutaneous, for example, this patient's swelling is subcutaneous, skin is pinchable, swelling became more prominent on extension of the neck. So it is subcutaneous swelling. Then how do you know the relationship to the sternomastoid muscle? By contracting sternomastoid muscle. How do you make this left sternomastoid contracted? How do you make the left sternomastoid muscle contracted? You must specify. Turning head means this is turning head, this is turning head. You must specify regarding the chin. I am asking you to tell me about how do you contract left sternomastoid. That means you tell me to which side the chin has to be turned. Very good. Chin towards right side. Against resistance. That means you keep your hand on the chin on the right side and ask the patient to forcibly turn the chin against your hand's resistance. Then you can see the sternomastoid muscle will go into contraction. You can see the muscle has become more stiff. Now what do you observe here? What is happening to the swelling? What is happening to this swelling? size. So it's become more prominent. More prominent means it is superficial to the muscle. Now my question is, it is in the thyroid region. Can this be thyroid swelling or not? Can this be a thyroid swelling or not? Only 4 of you are participating. It seems others have determined not to participate in discussion. My message to other students is, you participate in the clinical discussion, at least for the case taking. So whatever it is, don't tell me about the fascia. Just I am asking only one question, simple question. Is this a thyroid swelling or not? You gave me the answer as no. Yes, it is not a thyroid swelling. Swelling superficial sternomastoid, that means not from thyroid. If it is a midline swelling, then you have to test for both the sternomastoids. So how do you test for both the sternomastoid? You make the patient to flex the neck against resistance, not to one side. Then that will make both the sternomastoids contracted. So you can see here, the swelling has become less prominent. That means it can be a thyroid swelling. That means it is deep to the sternomastoid muscles. So the first test is check whether the swelling is from the skin, subcutaneous tissues, or relation to the deep fascia of the neck. Then test whether the swelling is moving on swallowing. So the swelling is not moving on swallowing. If it is cystic swelling, it can be due to a cystic hygroma, dermoid, or a cold abscess. What are the signs of cystic swelling? When do you say a swelling is cystic? Two signs are there. You told me only one sign. Tell me the other sign also. Indentation is not the sign for a cystic swelling. It is for pultaceous material. Yes, Manogi, you're right. It is soft and fluctuation. So you see for consistency and fluctuation. If consistency is soft and swelling is fluctuant, we call it as cystic swelling. So all these signs, these are all the basic signs. You must be thorough with these signs. So signs of cystic swelling means soft in consistency and fluctuation is positive. Transillumination may be positive if it is having clear fluid. Transillumination will be negative if it is containing opaque fluid. So cystic swelling means it can be due to cystic hygroma, dermoid, or cold abscess. Cystic hygroma is translucent. Dermoid and cold abscess are not translucent. Then solid swellings, lipoma, thymic swelling, extrinsic carcinoma of the larynx. So a swelling in the midline of the neck, which is not moving on swallowing, you have to consider these points, these things. moving on swallowing. Then you must do the test for movement on protrusion of the tongue. Movement on swallowing is present, but movement on protrusion of the tongue is absent. Most commonly it is thyroid swelling. Then the other swellings being. So tell me the swellings that moves on swallowing. Swellings which move on swallowing. What are they? There are 4 swellings. Already I mentioned 2 swellings. Tell me about the remaining 2 swellings. Yes, thyroid, subhyoid bursa, thyroglossal cyst, and the pretracheal and prelaryngeal lymph nodes. Those are the swellings which move on swelling. In this, only one thing will move on protrusion of the tongue, the remaining will not move on protrusion of the tongue. Movement present means it is thyroglossal cyst. The other possibility is what is the other swelling which moves on protrusion of the tongue apart from thyroglossal cyst? What is the other swelling which moves on protrusion of the tongue apart from thyroglossal cyst? Actually, it is not lingual thyroid. You can say it is ectopic thyroid. Ectopic thyroid. Yes. Very good. Median ectopic thyroid. So, this patient is having a nodule here, and patient is asked to swallow. You can see the movement on swallowing. So, the swelling is moving upwards on swallowing. Hence, it is a thyroid swelling. So, is it thyroid or not? This thyroid swelling has the following characters. The shape of the thyroid. So, the swelling will be having the shape of the thyroid gland, or it may be like a nodular swelling in the region of the thyroid gland. The swelling is deep to the sternomastoid, strap muscles of the neck, and deep fascia of the neck. It moves on deglutition. Then what you do is you palpate the swelling. So this is the position. You must stand by this behind the patient. You have to keep your thumb over the occiput of the patient behind. So you keep the thumb over the occiput of the patient, and what you should do with your thumb, with the both thumbs, you must try to flex the neck. So you must keep the neck of the patient flexed forwards. What will be the intention of the patient? Usually, whenever you are examining, they want to expose their most of the part of the neck. So they try to extend and show you the whole mass. They always feel that when they flex their neck, the swelling gets concealed. So what you do is you have to keep your thumb over the occiput and press it forwards, and keep your 4 fingers, except the thumb, on the front of the neck of both hands, and then now you palpate. Palpate the both lobes of thyroid gland, isthmus of thyroid gland, trachea, then sternomastoid muscles, then carotid vessels, then lymph nodes. So after you palpate for the whole thyroid gland, that means you check for the site, size, shape, surface, skin or the swelling, consistency, margins, mobility. All these things you do it by physical examination of the swelling. Then you must check whether it is unilateral or bilateral. For example, this swelling. The swelling is present on the right side. Whether the left lobe is enlarged or not. How to check? What you do is you keep your hand on the right side of the swelling and push it to the left side. Then you can see here you are not able to see the left lobe. But once you push it to that side, you are able to see the left lobe here. That means it is a dominant nodule. If you don't see this nodule, or if this swelling is not seen, that means this becomes a solitary thyroid nodule. What is the importance of dominant nodule? What is the importance of dominant nodule? Risk of malignancy, is it low or high? Yes, very good. The risk is low. That means it becomes half of the solitary thyroid nodule. Very good. So you push the lobe to the other side and feel the tracheal rings on the other side. If you feel the tracheal rings on the other side, you will be able to feel the swelling here, if it is a dominant nodule, or any nodules are there that can be felt. So you keep your fingers over the trachea on the left side and now ask the patient to swallow. Even a small nodule, you will be able to feel it under your fingers. So you feel whether the mass is felt or the tracheal rings are felt. So this test is done to differentiate solitary nodule from diffuse goiter as well as from dominant nodule. If you see a large swelling here, there becomes a diffuse goiter. If it becomes just mild enlargement, means it is a dominant nodule. So the fourth point you have to check is whether the patient is having features of thyroidoscosis or not. Already I told you 4 cardinal features of thyroidoscosis. You check for them. What are they? What are the cardinal features of thyroidoscosis? Very good. These are the 4 cardinal points of thyroidoscosis. That means goiter with bruit, tachycardia, tremors of the fingers, and exophthalmos. Very good. So the cardinal features of thyroidoscosis are tachycardia, tremors, bruit over the gland and over the superior pole, exophthalmos. Eye signs are present mainly in the primary thyroidoscosis. Then test for features of malignancy. The features of malignancy being infiltration, tracheal infiltration, mobility over the trachea is restricted, carotid sheath infiltration, look for the Berry sign. Recurrent angle infiltration, there will be symptom of hoarseness of voice confirmed by laryngoscopic examination. Strap muscle infiltration is rare and is detected by restricted mobility of the swelling. Esophagus infiltration, there will be dysphagia. Then second feature is induration or hardness of the swelling. Then involvement of lymph nodes or distant organs, especially the bones. So these are the features of malignancy. So this is how you check for the Berry sign. There are no features of malignancy in this case, of course. Then check whether it is autoimmune or not. Autoimmune thyroid goiter presents as a diffuse goiter. The swelling is tender, firm, and elastic with boss-related surface, usually associated with hypothyroidism. So, when a patient with swelling in front of the neck or in the thyroid region comes to you, first thing what you must check is you take the history, just like for any swelling. But for a swelling in front of the neck means you have to take. So what is the history for a history you take for any swelling in general? Duration, mode of onset, progress of the disease or progress of the swelling, pain, similar swellings elsewhere. So these are the things you must make 5 points. I repeat, duration, mode of onset, progress of the swelling, pain, associated swellings elsewhere. So these are the 5 points you take in the history for any patient with swelling anywhere in the body, be it in the abdomen or the scalp, over the neck or anywhere. In addition to these 5 points, if it is a thyroid swelling or a swelling in the region of the thyroid, you must take some additional points in the history. What are they? Toxic symptoms, hypothyroid symptoms, malignancy symptoms, inflammatory symptoms. So we have seen thyroid can be inflammatory, neoplastic, toxic, simple. So take the about 3 inflammatory signs means painful, tender, associated fever may be present. Neoplastic, features of infiltration, that means hoarseness of voice, pain, rapid increase in size of swelling, associated swellings in the lateral side of the neck or over the bone, somewhere over the skull. I'm talking about only history, that means symptoms. Then toxicosis, increased weight loss, increased appetite, preference for cold, sweatings, feeling of anxiety, palpitation, breathlessness, weakness, feeling exhausted or tired, even for small work. So these are the toxic symptoms. So history taking is number 1 about the swelling in general. Number 2, swelling in front of the neck, special points. So those things you must take. Then you examine. How do you examine? See the general condition of the patient. That means anemia, jaundice, pallor of the tongue, clubbing of the fingers, edema of the feet, etc., etc. Local examination, skin pinchability test, deep fascia stiffness test, sternomastoid muscle contraction test. That will tell you about the plane of the swelling. Next, you check whether it's thyroid or not. How? Make the patient to swallow. Movement on swallowing present. Then check for movement on put through the tongue. Then you check whether it is unilateral swelling or a diffuse swelling. Then you check for signs of toxicosis. Then you check for signs of malignancy. Then check for signs of inflammation. So these are the 6 points. Plane of the swelling, thyroid or not, unilateral, bilateral, toxic symptoms, toxic signs, malignancy signs, inflammatory signs. So these points you have to do. So that is the symptoms, these are the signs you elicit. So after you elicit the symptoms and signs, then arriving at a clinical diagnosis. Whether it's solitary or diffuse, first check it out. If it is solitary, non-toxic, non-malignant, that is simply, we call it a simple goiter. So it is a solitary nodule goiter. It can be adenoma, simple nodule, cyst, well-differentiated carcinoma of thyroid. So these are the solitary swellings. For the diffuse swelling means parenchymatous goiter, colloid goiter, nodular goiter, or Hashimoto's thyroiditis. Then features of toxicosis present. Solitary swelling means toxic nodule. Diffuse swelling means primary toxicosis or secondary nodular toxicosis. Then malignant. Features of malignancy present means solitary means it is carcinoma, diffuse also is carcinoma. Features of inflammation means Hashimoto's thyroiditis, either solitary or diffuse. So this is how you will arrive at the diagnosis. I have shown you the patient. That patient is having the following features. The swelling moves on swelling, unilateral swelling, no features of toxicosis, no features of malignancy, and no features of autoimmune disease. Now, what is your diagnosis? Yes, it is solitary nodule goiter. Hence, clinical diagnosis is solitary nodular goiter, also called as solitary thyroid nodule or STN. What conditions cause solitary thyroid nodule? Of course, previously also I asked this question. Now also I am asking again. What diseases of thyroid produce a solitary thyroid nodule? Nizami said that carcinoma, you have to mention it as differentiated carcinoma. Carcinoma means it can be medullary carcinoma, it can be lymphoma, or it can be anaplastic carcinoma. So we're talking about solitary thyroid nodule. So you must specify that a differentiated carcinoma. Very good. You have all mentioned correct answers. Wonderful. So just I will, this is about case taking of a thyroid case. Tomorrow we will have discussion of about some 6 or 7 cases. So if you want to participate in the case discussion, we will have case discussions tomorrow. If you don't want it, we will go to the topic of breast diseases. So I will talk about breast diseases tomorrow. Tell me your idea. Anyway, I will take the poll. What about others? Okay. 75% wanted to have the case discussion on the thyroid. So I will go for the case taking tomorrow. Okay, that's fine. Now just I will say a few points about the we'll go to the topic of the operations on thyroid gland. So when you talk about operations on thyroid gland, so this takes only about 5 minutes. I will take 5 minutes and then I will close the session today. Or do you want me to take it tomorrow? Shall I continue now or shall I take it tomorrow? Okay. Theodore Cocker is a pioneer in thyroid surgery. So whenever you think of thyroid, you must always remember this great name, Theodore Cocker. He has pioneered these surgeries: thyroid surgery, cholecystectomy, shoulder dislocation, duodenal mobilization, and he discovered a clamp which goes by his name, that's called Cocker's clamp. He has discovered one thyroid gland dissector, then thyroid retractor, and for his great service in surgery, he was awarded Nobel Prize in Surgery in 1909, especially for his thyroid surgery. Operation thyroid gland, types of operations: lobectomy or hemithyroidectomy, subtotal thyroidectomy, total thyroidectomy, near total thyroidectomy, isthmusectomy. So these are the procedures you do on the thyroid gland. So this is the thyroid gland. Here are the parathyroid glands. This is trachea, esophagus, recurrent laryngeal nerves. If the person gets a solitary thyroid nodule, if you remove the nodule containing lobe along with isthmus, you call it as lobectomy. Then what is subtotal thyroidectomy? You keep about 10 grams of thyroid gland in the tracheoesophageal groove and take away the remaining thyroid gland along with the isthmus. then it is called subtotal thyroidectomy. What is total thyroidectomy? If you remove the whole thyroid gland with preservation of parathyroids and recurrent laryngeal nerves, then it is called the total thyroidectomy. Near total thyroidectomy, that is lobectomy plus subtotal lobectomy. So you remove whole of the one lobe, isthmus, and the other lobe, you do subtotal lobectomy. So some surgeons, they do this procedure for well-differentiated carcinoma of thyroid gland. Why they preserve this one? By preserving the slice of thyroid here, you will be able to preserve the parathyroid gland. Isthmusectomy, this is removal of the isthmus. So procedure of thyroidectomy, what you have to do, you have to isolate the pedicles. That means superior thyroid artery and vein, the middle thyroid vein, the inferior thyroid artery, the inferior thyroid vein, and remove the gland from the trachea. While you are removing the gland from the trachea, you must protect recurrent laryngeal nerve and parathyroid glands. So that is thyroidectomy operation. First, what you do, you ligate the middle thyroid vein and ligate it. Then you will be able to mobilize the gland on the posterior side. So once you mobilize the gland, you will be able to see the recurrent laryngeal nerve in the tracheoesophageal groove. You dissect upwards and you ligate the superior thyroid pedicle individually. Individually means you ligate all the branches of veins separately, all the branches of arteries separately. If you do like that, you will safeguard the external laryngeal nerve. Or else if you just put a clamp here, the clamp can include the the external laryngeal nerve also. So that is why you dissect it and pull the gland laterally apart and ligate it. The nerve will be in the cave of Reeves. The Reeves is nothing but, space of Reeves is nothing but the space between the inner side of the thyroid gland and the side of the pharynx. Then you ligate the inferior thyroid artery. So while you ligate the inferior thyroid artery, you must safeguard the recurrent laryngeal nerve. Otherwise, nerve may be damaged. Then you ligate the inferior thyroid vein and separate the gland from the trachea, remove it. So this is the position of the patient. The patient, you have to keep a sand pillow or sand bag behind the shoulders of the patient. This will make the neck extended. So keep the neck extended, drape it, head and elevate sandbag behind the shoulders to extend the neck, head draped with protection to the eyes. You make an incision in the crease lines of the neck. So these are called the crease lines. You inside the skin, subcutaneous tissues, that is platysma, and you dissect the flaps upwards and downwards. Then you make a midline incision in the deep fascia. So this will expose the strap muscles. You dissect this in between the strap muscles and then you retract the strap muscles. Once you retract the strap muscles, you will find the thyroid gland. You dissect on the lateral side. You will find the middle thyroid vein. So first you ligate the middle thyroid vein. Once you ligate the middle thyroid vein, then you can mobilize the gland either with finger dissection or with instrument dissection. You separate the gland from surrounding tissues. This is superior thyroid artery and vein. So individual branches has to be ligated close to the thyroid gland, not far away from the thyroid gland. You should very close to the thyroid gland. Then inferior thyroid artery is found on the posterior border of the thyroid gland, and you have to ligate it, but you have to ligate it only after isolating the recurrent laryngeal nerve. So how is it going? You look at the recurrent laryngeal nerve and then you ligate it. So sometimes the nerve goes between the branches. So you must look at the nerve, then only you will be able to safeguard the nerve. Otherwise, you will damage the nerve. So the nerves are ligated. These are the parathyroid glands. You can see the parathyroid glands. So the parathyroid glands will be there in the capsule of the thyroid gland. So what you have to do is you have to incise the capsule all around and separate the parathyroid gland from the thyroid gland. So you can see here, this is the parathyroid gland. So this is the parathyroid gland. So you must separate the parathyroid gland along with the blood supply. The blood supply comes from the inferior thyroid artery. So a branch will go to the parathyroid gland. So you must safeguard that branch also. Then only it will be vascular. Otherwise, it will become avascular and die. So this is parathyroid separate. So parathyroid glands can be safely separated from the thyroid gland and kept aside. Then you dissect the thyroid gland from the trachea. If you are doing lobectomy, you cut the isthmus at its junction with the other lobe and remove this lobe. This is the lobectomy operation. Place of injury to the recurrent laryngeal nerve at the Berry's ligament while ligating the inferior thyroid artery at the lower pole isolation. Subtotal means vascular isolation is same as before, but you don't separate the whole gland from the trachea, but you cut the gland such that only 10 grams of tissue is left behind and remaining thyroid gland is removed. And this thyroid gland will bleed, so you have to ligate all the branches. So this is subtotal thyroidectomy. So this is a remnant. So all the bladders are being ligated. So this is the procedure of hemithyroidectomy. If you do it on the both sides, it becomes the total thyroidectomy. So I will close the session here. Tomorrow we will have a case discussion on all the thyroid diseases. So come prepared, and all of you should participate. Then only you will get the satisfaction that I have told you completely about thyroid and you have followed the disease. Okay? See you tomorrow at 4 p.m. Thank you.